I think that the new combination of atezolizumab plus bevacizumab is the new standard of care based on the results of the IMbrave 150 trial. In some countries, the combination is already approved, so this combination is already the new standard of care in first line. In some other countries, it is not yet approved, so it will be in the near future the new standard of care. And as you know, in China, there is the Orient 32 trial that is very similar. So the combination of an anti-PD-1 plus an anti-VEGF, so a similar combination that will be probably approved in other countries. So I think that the current standard of care, so represented by lenvatinib and or sorafenib in first line, will not be anymore than the standard of care in first line, unless for people who are not suitable for the combination of atezolizumab plus bevacizumab. So this will be the new standard of care in first line for all the patients that are candidated to a combination of treatment. For other patients who are not suitable for immuno-oncology drugs or for bevacizumab, lenvatinib or sorafenib can still be a good option in first line. I think that this is a very important question and a very difficult question. Physicians should be aware of this new data and should be aware that the treatment algorithm for patients with an unresectable HCC is changing or will be changing. So first, they need to be aware of the new data. And about the second and third line, this is the most difficult question because we don't have any data yet about subsequent lines after atezolizumab plus bevacizumab. So according to the labels, only sorafenib can be used after atezolizumab plus bevacizumab because it is the only drug that is approved for hepatocellular carcinoma without any indication of first line or second line and so on. But if we think of the scientific, we think from a scientific point of view of if we think of the rationale, I don't see any reason for prescribing sorafenib and, for example, not lenvatinib or other tyrosine kinase inhibitors, or maybe in the future a combination of two different checkpoint inhibitors. So at least at present, I think that after atezolizumab plus bevacizumab, we will use the previous first line treatment, so probably sorafenib and or lenvatinib, and then the previous second line treatment, so regorafenib or cabozantinib or ramucirumab. But if we look, for example, at the ESMO guidelines, after atezolizumab plus bevacizumab, they accept all the other treatment approved based on phase 3 trials, so sorafenib, lenvatinib, regorafenib, cabozantinib, ramucirumab. I think we need to generate data, probably not from clinical trials, but maybe real world data to see if there are any differences between the different tyrosine kinase inhibitors or other drugs after atezolizumab plus bevacizumab. And there are ongoing and there are planned trials testing different combinations after atezolizumab plus bevacizumab. Another important question, there are already some data in early stage HCC, not exactly with the combination of atezo-bev, but with immunotherapy in the neoadjuvant setting. And they are very promising with an important response rate before surgery, so in the neoadjuvant setting. And looking also at the translational results of this trial, you can see that the tumor immune microenvironment completely changed after neoadjuvant immunotherapy. So I think that in the future, atezolizumab plus bevacizumab will be an option for patients candidated to surgery and maybe who need a decrease in tumor diameters, a downsizing of the tumor. And probably there will be clinical trials in this setting. For patients with the intermediate stage HCC, there are already ongoing trials testing atezolizumab plus bevacizumab versus local regional treatment, for example, TACE, in patients with an intermediate stage, but with important liver tumor burden. And we will see in the future if for these patients, a systemic treatment will be better than a local regional treatment. And there are also trials combining local regional treatment and systemic treatment, and we will see. So there are two important new settings for atezolizumab plus bevacizumab. We don't have data yet, but we will have it in the near future. For the first part of the question, so the diagnosis, I think there are still too many patients with the HCC who are diagnosed according to radiological characteristics based on the ALSLD guidelines. Now that we have different treatment options and we need also to generate data, translational data, to try to identify biomarkers and to try to identify which patients should be treated with which drug. I think that the biopsy is mandatory, so we can have a histologic exam, the correct diagnosis, and we can also have tumor tissue for translational research. Also, it's important to note that in recent years, the intrahepatic cholangiocarcinoma increased in incidence, and in some cases we treat patients like they have HCC based on radiological findings, and then they had intrahepatic cholangio, and this is completely wrong, and we don't do the best for the patients. So first, for the diagnosis, we need the biopsy and not the radiological criteria. And second, I don't remember the second part of the question, but you send it to me, so okay, the difficulties in the treatment and the future treatment prospect. Yes, more or less, we have already discussed about this. So we have different options. So in the future, we will have probably systemic therapies also in the early and intermediate stage. And so if we, for example, in the future, we'll be treating patients with intermediate stage with atezobev, maybe combined with a local regional treatment, then I don't know what we will be able to do in the advanced setting. If we would like to focus on the advanced setting, as I said, we have atezobev, that is now the new standard of care, but there are ongoing phase 3 trials combining two different checkpoint inhibitors, anti-PD-1 or anti-PD-L1 plus anti-CTLA-4, or combining a multi-kinase inhibitor plus immune checkpoint inhibitor. So maybe in the future, and hopefully for the patients in the future, we will have different combinations available in first line. And so we will need to find the biomarkers, tumor tissue biomarkers, or blood biomarkers, or clinical biomarkers, to select which patients should be treated with which combination. And we need to define the treatment algorithm. So after one or the other combination, what we need to prescribe in second line and third line, and so on.